Thank you for watching our on-demand webinar, How Dissatisfaction Drivers Can Optimize Satisfaction. Today we're going to talk a little bit about leveraging complaints, appeals, and grievance data to improve member and provider satisfaction. My name is Daniele Chenal. I'm the Director of Healthcare at Inspire Innovations, and I'm also the co-founder of CAG Solutions. CAG Solutions provides a case management and analytic appeals and grievance platform. And we are also a member of the Managed Care Resource Alliance. And I have with me this afternoon Barry Volin. Good afternoon, Barry. And I'll let Barry introduce himself.
Hey, good morning, Danielle. My name is Barry Volin. I am also the CEO of the Managed Care Resource Alliance. And I've done a variety of different CEO, COO roles in the managed care industry. I was the startup CEO of Aetna Better Health of New Jersey, as well as the startup CEO of Centers Plan for Healthy Living in New York. And I am pleased to be here to have this discussion with Danielle.
Awesome. Great. Barry and I are going to kind of talk about two topics today. So the first topic is really kind of aimed at Medicare Advantage plans. And so what we want to talk a little bit about is the shift in the CMS Star rating from what was historically based on clinical measures. So a great deal of the rating was based on clinical measures, and that's shifting to member experience. So we want to kind of provide a little background on that and then talk about how you can leverage complaints, appeals, and grievance data to improve CAP scores and member experience. So that's our first topic. And our second topic is really aimed at any health plan, whether you're a government program like Medicare or Medicaid or commercial. And again, we want to kind of talk about how you can use complaints, appeals, and grievance data to do root cause analysis on the drivers of member and provider dissatisfaction. And then how can you, basically take on initiatives for enterprise-wide operational improvements. So in this portion of the discussion, we're really going to just kind of give you a baseline and a little background on the CMS Stars ratings and kind of some of the things that are changing. So Barry, I know that there's a pretty significant impact on health plans in terms of revenue. So I thought maybe you could tell us a little bit about that.
Sure. I'm going to delay the discussion on the detail behind how STAR scores are arrived at and just go through some of the implications of what the STAR score is. As you can see, I've broken this down into both an enrollment activity and into a benefit design implication. For those plans that receive 5 stars, and there are only a handful of them across the country, they have not only an enhanced revenue of 5% on top of their community-based premium, they also get a special 5-star enrollment period, essentially allowing people to enroll into their Medicare Advantage plan throughout the entire year. The standard Medicare Advantage plan typically has an open enrollment period that lasts about 6 weeks, and that's the primary time for most enrollment, unless you're a 5-star plan. Mm-hmm. On the enhanced benefits, what I'm referencing here is the additional 5% premium dollars oftentimes gets used to develop a set of enhanced premiums over and above the standard Medicare Advantage plan benefits. And those typically include things like dental, vision, and over-the-counter benefit. In some cases, there's even an offset to some of the Part B costs. The importance here is because of the enhanced benefits and because of the additional dollars, you get a much, much greater draw of new members into your plan. The next slide will show the net impact over the last 6-7 years, and you could see a dramatic shift in the number of members that are enrolled in 4-star and above plans. Last year, we were running 81% of enrollees, total enrollees were in 4-star plans or better. That's because those plans have reached that 4-star plus level, have gotten their enhanced benefits, have made themselves far more attractive in the open market, and hence those members are drawn to them.
So do you want to maybe then talk a little bit about this shift from what was historically clinical centric measures to now member experience and administrative measures and kind of what that's looking like?
We look at the pie charts and the sections and the way they're weighted, and you look at CAP scores, simple CAP scores. 3 years ago, they only comprised 17% of the total score. In 2021, they were at 32%, and that will continue to increase as the years progress. So the importance of the perception of the member's experience will drive that much of the overall weighting of the score that the plan gets.
For me, it was really helpful when I saw specifically the members, the measures that we're talking about. Again, to your point, the weighting on these measures is going to go from 2 times the value to 4 times the value. And that's really significant, right? And so you could see a great deal of this. While some of the measures do revolve around administrative areas, such as timeliness of appeals and the reviewing of appeal decisions by IREs. So some of it is administrative, but a great deal of it does come from the CAP surveys. And so all of those items highlighted there are going to go from a 2x weighting to a 4x weighting, starting with the 2021 data collection period, which will affect the 2023 stars, and going forward. So again, just kind of putting out those details to help people kind of, what exactly do we mean when we say member experience? These are the areas that we're talking about. I think the bottom line is that even if you continue to do well on your historical clinical performance, you're going to have to do a good job in member experience to get to that 4 and 5 star level. I think we're going to turn our conversation a little bit to, now that we kind of have some of that background, how can you use complaints, appeals, and grievance data to better understand dissatisfaction drivers and then improve member experience, and then therefore in turn can help improve your star ratings? Your data, you should be able to, from your complaints, appeals, and grievance data, look at the top drivers or the top ranking contributing factors to dissatisfaction. And in the next couple of slides, I am using charts that come out of our CAG analytics solution. And of course, ideally, we would love everybody to use our solution. But putting that aside for a moment, I think the key takeaway is not so much the tool itself, but the data, right? And in order to do this kind of analysis, you have to have the data necessary to do it. First and foremost, you definitely should be able to look at the top ranking contributors to both appeals and grievances. So in terms of, how can we then use this data to help us with CAPS? And again, it's member perception, so it's not really, quantitative. But if we look at the top contributors that are driving complaints and grievances, we can kind of correlate those to the very things that the CAPS survey is measuring, right? So you could see by my chart, right, we can measure things like quality of care complaints and customer service and access to care and so on. And those directly relate to the types of questions that the member is being asked. So if you can, at a minimum, you want to be able to get those top ranking categories at a high level. Ideally, you could then take it the next step down, right? So it's not really enough, I think, to know that you have a customer service problem. It's kind of a little too high level, right? And I've also read like a lot of plans really struggle with member satisfaction because they don't always really know the detailed drivers behind it, right? It's really hard to say, well, is it demographic? Is it due to certain things? Again, if you can classify and subclassify your grievances correctly, you can get at that deeper level of information. So this just shows that for customer service, for example, we can see, is it based on hold times are too long. Maybe people are not satisfied with the website. Maybe they're not getting the correct information. And then I could further drill into this and say, if it's not getting correct information, is that due to a certain agent or agents, that maybe need to be retrained? Is the hold time, due to certain types of cases? Or again, I can look at certain geographic things or demographics. So that's how we want to be able to really dig in and analyze the data. And then the hard part, or the actionable part, is, now that we kind of understand where those pain points are, what kind of initiatives can we put in place that then we could monitor this on an ongoing basis, right? So we should be looking at the trends in these top ranking areas to see if those trends are going up or down. It is a reflection of more than likely the way that your members are perceiving the customer service and quality of care that they're getting. So I don't know if you have any other thoughts around that, Barry.
I do. It's interesting. When I read this first, and we talked about this over time, and now I'm hearing it again, what's going to be critical is that the organization take these data implications that we've identified through the analysis that you've laid out. We need to weave all of these implications into an organizational-wide solution. We need to ensure that all those touch points are complying with the findings that we've identified as being critical issues in how they're managing the workflow, how they're managing the process. More importantly, is how they're interacting with the member.
I want to take a moment to circle back around to the other administrative measures that are impacted by this weighting change. All three of them are measuring the performance of the A&G function itself. The first is fairness of decisions. This is when a plan upholds a decision and has to send it to an independent review entity. And there are a couple of actions and ways that you can use data to help you. So the first is using the decision database on CMS's website. So when you have a difficult case that you're going to be submitting to an IRE and you want to prevent a potential overturn, you can use this decision database to obtain past decisions that the IRE has made on similar cases. And this is not just your own cases, but this is any case that they've made a decision on for any plan. The second thing, of course, is to use your own data to reconcile the data that CMS is providing on IRE decisions and make sure that it's accurate. And then the third is to be able to assess the root cause of your overturns. In terms of plan timeliness of decision, this too, you should be continuously monitoring your timeliness and again, assessing the root cause of what might be causing untimely cases. Is it certain types of cases, certain providers, certain case handlers, certain people making those decisions, right? So being able to drill into that data. And then last but not least is complaints per thousand member. And you really should be continuously monitoring your complaints per thousand member, and same thing, assessing the root cause.
Now I want to turn to really any plan in terms of how CAG data can be used for enterprise-wide operational optimization. We put together a couple examples. Barry and I have talked about this in the past. So the kinds of insights that we can get through complaints, appeals, and grievance data, we're just going to talk about a couple items and then what kind of actions a plan could take. So the first one's copay and benefit complaints, right? And again, through your analytics, you can identify if those are around certain types of benefits, maybe dental benefits, vision benefits, in certain areas, so that you can then figure out what types of actions you could take at the member, provider, or plan operations level. And so I'm going to let you, Barry, if you don't mind, maybe you could just kind of talk about a few of these points.
Sure. So when we talk about a copay or a benefit complaint being filed by a member, oftentimes that can be based on a variety of different sources. First and foremost is Does a member actually understand what the benefits are that they have signed up for? Do they understand there is potentially a copay or a coinsurance or a deductible or a combination of the three of those based on the type of benefit and the timing? So there's some clarity that's needed on the part of the member. And we recommend that all get incorporated into some sort of onboarding and member orientation so that there's constant clarity presented to the new member, and then that detail is available to them on an ongoing basis. Second is when health plans go through an annual benefit design. They go through, they work with their actuaries, they work with their marketing people, they put together a proposed set of benefits for the following year. And typically they're built around what they think will be the most marketable benefit package out there to draw enrollment in. What they don't do is provide a very detailed explanation of what those benefit changes are. They comply with the rules, and they do in fact send out an annual notice of change, which will identify in a series of bullets what the benefit changes are. But many people don't understand what that is, especially because it comes out at the time when all the Medicare Advantage plans are out marketing to people, and they're sitting with piles of marketing material on their desk. Third, this is an obvious thing. Members need better education. They need it at the time they enroll. They need it on an ongoing basis. Otherwise, somebody once said an informed customer was the best customer. We have to set that, and we need to put that into place. And the last bullet here for me is for anybody who was taken advantage of a benefit, and then the benefit was paid partially or in full, and they've received an explanation of payment around that benefit. And if there was a copay involved, or a coinsurance, or a secondary carrier, that explanation is written in language that I've never read. I can't understand. It meets all the compliance rules. But in terms of understanding and legibility, most people have no idea of what we're saying. We need to put it into a language that the layperson understands and understands clearly what their next steps are. On the provider side, again, on the copay, have we been clear about what the benefits are to the providers? Do they understand that we had a change this year or last year or next year? There are going to be additional copays or the change in deductibles. If they haven't been informed, then they're going to be billing incorrectly and their expectations are going to be wrong. And we ultimately are going to be submitting the wrong bill to the member, which is going to drive those type of complaints. How often do we do updates to our providers, and not just by posting an update in our provider manual on our website, but do our provider service people actually go out and spend time with not just the providers, but the providers and their billing agents to walk them through those changes? And then do they provide them with ongoing real-time feedback as to what our members are facing, the type of complaints we're getting relative to what we've taught the providers? If they haven't done that, then providers are working under the best knowledge they have, albeit it could be old, it could be stale, it could be totally inapplicable. Plus, they don't know how to bill unless we tell them how our billing is set up, what sort of claims, what sort of changes have been made. Under the public health emergency of COVID over the last several years, there have been any number of billing exceptions and procedural exceptions that have been made and allowed. Have we continued to provide that information back to our providers? Do we let them know what they can and they can't do? The last item for providers is the whole question of COB, coordination of benefits. Do we expect our providers, our primary providers, to coordinate benefits and coordinate secondary carriers? Do we, the plan, take care of that? And are we clear to both the provider and the member how that happens? The last is just plan implications. And what I always think about is the contracting group goes out and puts in place very complex contracts with very, very sophisticated medical systems. And then how do we turn that sort of sophisticated contracting language into claim configuration to ensure payment? do we, after we've done the claim configuration, do we go through a very extensive set of user acceptance testing to ensure that all those steps are in place? And do we test the COB accuracy on a real-time basis? If not, we're going to end up with copays and benefit complaints. Now, the last thing I'm going to leave you with is, although we've categorized a variety of different genesis of these type of complaints, I don't want anybody to think that it's only one of these items that could drive this. It could be multiple combinations of these. And just remember, we've used these as only examples. They are not all inclusive. It is by far not an exhaustive grouping of issues, but it could be any combination of these. And hence the reason I said earlier, we really need to look at it through the eyes of the member, through the life cycle of the member, and all the touch points that the member goes through. Danielle?
Yeah, you made me, as we're talking about this, and I'm constantly trying to figure out how to help our clients utilize this data. And this was something we've talked about before too, which is, does this information, does this knowledge that resides in the complaints, appeals, and grievance data get to these other organizations in order for them to take these type of actions? And my guess is in many cases it doesn't. So I think one of the key things that we're also trying to convey is, it's not only that we can get these insights from the data, but we want to be able to then pass that data on to these other organizations so that they could take these actions in accordance with where those complaints and appeals and issues are coming from, right? Because all of these things, you're probably doing them across the board for all types of things, but how do you prioritize those that are driving some of the dissatisfaction, right?
Yep.
So it's really sharing that data and getting it out there. So this is just yet another example. So we can, maybe talk a little bit about this. So again, provider payment disputes, we can, get down into a lot of the details that are driving provider payment disputes. And provider satisfaction, as you have said many times, Barry, is equally as important as member satisfaction. So I thought that, maybe you could touch upon some of the types of things that, as we identify issues in payment disputes, what kinds of, again, actions can be taken based on that.
Yeah, let's start with the premise that the most critical point in time for a member's satisfaction is that couple of minutes that they spend with their provider. And if their provider is not happy with the way the plan has been treating them because of administrative issues, they will communicate that, and maybe not that directly, but there might be a suggestion that another plan might be more apropos for them, that look at other benefits, or just it could be used as a venting session. The other thing is, just because a provider has not filed a dispute on payment doesn't mean that the plan is paying correctly. Plans can be overpaying inadvertently, and nobody's going to complain about being overpaid. So there is an issue here around ensuring the accuracy of the payment. Providers should be paid every penny they are entitled to, not a penny more, not a penny less. In this case, where we talk about some of the reasons that a provider couldn't file a payment dispute. On the member side, the member might go to the provider and not understand what coinsurance, all those details we talked about before are. And there is a broad misunderstanding of the payment and ultimately what is paid. You have to understand, the member has to understand what balance billing is. And as a Medicare Advantage member, they have to understand they can't get balance billed over and above the Medicare standard fee schedule, but they can be billed for copays and coinsurances that are part of their Medicare benefit. Many times they don't understand the difference. We need to come up with, as I said earlier, simplified benefit explanations for members. On the provider side, the provider needs to be educated into what the payment structure is, and what their role of the provider relations staff is. And we need to be able to work with them at correcting both over and under payments on a real-time basis. This is going to be repetitive from the last one, but we still need to go back and evaluate how we configure claims. And are providers overbilling? Are they upcoding? Are we downcoding? Most recent article I saw by the OIG was that 18% of Medicare billing health plans inadvertently or intentionally denied claims that were actually clinically appropriate. We can't allow that to happen, just as we can't allow overbilling on the part of providers. We need to come to that medium where accuracy is what our target is.
Yep. And I totally agree. And I've seen, in plans too, like, when you start to see certain trends in the appeals data, oftentimes that's a very early indicator of issues or problems within the claims configuration. So again, if you're monitoring this, if you're evaluating this data, you may catch it, earlier in the cycle, right? To get those configuration changes made, so that it's not as, it's not a year or 2 years down the road before you identify and correct these problems, right?
Nope.
So the last one is payment overturns, and clearly, if you're overturning appeals, more than likely either you were really late and overturned it because you had no choice, but hopefully you're managing your timeliness. So hopefully that's not the case. And otherwise, there may be other systemic issues that are causing you to make those overturns. So again, Barry, maybe you can just elaborate on a few of these points.
Yeah, the simple one here is that we are overzealous in our denials, and we would deny a claim for a clinical reason or some administrative reason, in spite of the fact that clinically it was entirely appropriate. We need to be more empathetic or sympathetic to the needs of the member and evaluate it really based on clinical need, and perhaps put some of those administrative issues on the back burner.
Yeah. Yeah. And the same thing, just trying to look into these and see if there's patterns, right, in the overturns, and, try to get a better understanding of what might be some of the key reasons for those denials, and then be able to action that. I think, so I just wanted to maybe take a minute to summarize some of these points, and you can jump in as well. I think for STARS, for Medicare Advantage plans, I think, the takeaway certainly is, don't lose sight of your medical outcomes. No one is suggesting to not do a good job on clinical, but clearly to start to have a strategic focus on member experience and not to lose sight of those handful of administrative measures. All of it collectively is what's going to help you achieve those higher ratings, and then those revenue benefits. I think our point is to try to leverage analytics to help identify where dissatisfaction occurs, so you can improve member experience by better understanding it. And then, as we said, data in and data out, right? You need good quality data. Obviously, a purpose-built solution like ours is designed to validate the data, ensure that it's accurate, and give you that granular detail that you can use to do analytics. But if you don't have a system like that, then you need to make sure that you're improving the way that you gather data in the call center, enrich your data if you need to, your provider data especially, which can be really problematic for plans. So you can utilize third-party tools to help with that, and use technology and training to make sure that you're categorizing and capturing data consistently. And then I think, any initiatives need ownership. And I'm sure, Barry, in your life experience running, several plans, the best laid ideas are discussed in conference rooms. But if nobody champions these things and is assigned ownership, whether that's to distribute the data to these other departments to make sure they're educated or to take action on it, then it's kind of worthless, right? Like you have to make sure that there's ownership.
Yeah, and more than ownership, when we think about how many health plans operate, they operate in many different silos.
Mm-hmm.
Ownership of this is not just owning a set of activities within a silo, but owning this across the organization and having a variety of portions of the organization accountable ultimately for the outcomes. The other point I want to make is one you started, and it's the first bullet on here, and it's very important, and that is, if a health plan's been working long and hard to get 3 stars in its member satisfaction, working longer and harder won't ensure them 3.5 or 4 stars. This is going to require a very different change, a very different approach to how they analyze what's driving dissatisfaction, and more importantly, how they're going to organizationally change to get the impact that they want to have.
That's a really great point. Mm-hmm. Yeah, totally agree. So let me just say thank you, Barry, for joining me. This is really a great discussion. Hopefully it's informative for people. I think both you and I have a real passion to help health plans and help them be successful. So you folks can learn more either about the CAG solution, which you can learn about at complianting.com. You can learn more about my organization, Inspire Innovations, and the Managed Care Resource Alliance that Barry is the CEO of. All of them, I think, can potentially help you in your future endeavors. And again, we thank you for watching our webinar.